So I think there are a lot of different reasons why EMST might work for swallowing in addition to just expiratory strength and cough function. I agree that strength training is not the only approach we should be taking to improving swallowing or cough. They're both sensorimotor skills, basically. And so we probably also need to be using skill-based approaches to improve swallowing and cough.
In this episode, we speak to Professor Michelle Troche from Columbia University in New York, and we delve into the crucial topic of airway protection and its connection to swallowing and coughing. Together, we explore two approaches: Expiratory Muscle Strength Training, EMST, as a strength-based approach, and the skill-based approach called sensorimotor training for airway protection, short smTAP. Michelle explains the relevance of training airway protection in dysphagia management, the available evidence base, and limitations of both EMST and smTAP.
Hi, Michelle, and welcome to Dysphagia Matters. We're really happy to have you on today's episode. Would you like to briefly introduce yourself?
Sure. Yes, thank you for the invitation. I'm so happy to be here to chat with you all today. My name is Michelle Troche. I am an associate professor at Teachers College, Columbia University in beautiful New York City. And I've been here since January of 2015. And before that, I was at the University of Florida in Gainesville for many, many years. And over the years, my research has really begun to focus on kind of understanding cough and swallowing and their relationship to one another and how they degrade in people, particularly with dysphagia and in neurodegenerative disease, and with the ultimate goal of really developing kind of robust, efficacious treatments over time. And I think that we have done some of that. And so I'm excited to have the opportunity to share that today. And most of my clinical work has been in individuals with movement disorders.
Great. It's so nice to have you here today. We have invited you as an expert in airway protective disorders, particularly in people with Parkinson's disease, and we'd love to talk about two rehabilitative approaches. First of all, could you explain what airway protective disorders are and why they're relevant in people with Parkinson's disease?
Sure. So maybe we should start with what airway protection is. And so the way that we conceptualize it is that airway protection really kind of lives on a continuum of behaviors that are important to kind of keep the airway clear and ultimately keep a homeostatic environment in the lungs, hopefully. And so most of those behaviors, all of those behaviors are kind of overlaid on the respiratory system. And so one of them is swallowing at one end of the continuum, right? You need to prevent food or liquid or secretions from entering the airway. You can do that with effective swallowing. And then at the other end of that continuum is cough. It happens to all of us. Something goes into the airway, and cough is one main line of defense to clear the airway. Certainly others are things like throat clearing or expiratory efforts or reflexes. But the ones that we've been particularly interested in are swallowing and cough that kind of are at both ends of that continuum. And we know that individuals with Parkinson's disease, it's been well established over time that they have problems at both ends of that continuum. They have swallowing deficits, but also coughing deficits. And we think it's important that we care about both, because the reality is that in individuals with neurodegenerative disease, not just Parkinson's disease, you're probably never going to rehabilitate their swallowing to perfect, right? You're kind of always pushing against this degenerative process. And so they're likely to always have airway invasion in some capacity. And so it's important that we help to kind of upregulate or improve, bolster their coughing ability so that when that does happen, they can clear the airway effectively. And we feel like speech pathologists are the people to do that. And so that's not just the case in Parkinson's disease again, but I think across the continuum of individuals that have dysphagia.
So what options do we currently have in improving or rehabilitating airway protection?
Yeah, so I guess it depends on what end of the continuum you're thinking about. I think we have more treatments that have been identified that help with improving swallowing safety. So that one kind of preventative end of the airway protective continuum. And so, there are treatments now that have shown efficacy like respiratory swallow training, right, which has shown some improvement in swallowing safety. There have been exercises like LSVT that even over time has shown some improvement in swallowing safety. There's one that I think that has shown rather robust improvements is expiratory muscle strength training too, right? That has shown kind of improvement at both ends of that continuum, not just improvements in swallowing safety, but also improvements in cough. And there are many, many others, depending, I think, on the population of interest. But I think there are a lot fewer treatments that have been specifically designed to address cough versus just swallowing safety. And like I said before, I think that's really a gap in our kind of clinical toolbox, because we really do, I think, need to be addressing both ends of that continuum in our patients with dysphagia.
You have already mentioned the Expiratory Muscle Strength Training, or EMST. What is that and how does it work?
Expiratory muscle strength training is a type of respiratory muscle strength training that's focused on the expiratory muscles, right? Respiratory muscle strength training can address either the expiratory muscles, the muscles you use to forcefully breathe out, or the inspiratory muscles, the muscles that you use to breathe in. And this is specifically a device that was developed to place an external load basically on the expiratory muscles, with the idea of working almost like a strength training paradigm, just like you would go to the gym and lift weights to improve your biceps or something like that. This is kind of like lifting weights for your expiratory muscles. And the way it works is there's a little handheld device. It has a one-way spring-loaded valve, and the patient blows through the device. And if they develop the requisite pressure, the valve will open, and they've done one successful repetition through the device. And basically, you can increase the load placed on the muscles by increasing the resistance from the spring. And now there are devices that kind of can be very low resistance and some that can be very high resistance. But this specific type of device is one that's kind of a calibrated device that can be used over time in individuals with all kinds of different conditions. The specific device that shows up a lot in the literature now, the EMST 150, was developed at the University of Florida, so where I did my doctoral work. And I was kind of lucky to be there at that point in time because my mentor, my PhD mentor, Dr. Chris Sapienza, was one of the developers of the device. She's a speech-language pathologist, and she developed it together with Paul Davenport, who is more in the area of respiratory physiology, and Danny Martin, who was a physical therapist. And so together they developed this device initially to target the expiratory muscles, and a lot of their early work was in healthy young individuals, and that has certainly been expanded over the years into a lot of different populations.
And how is it related to swallowing? Because initially it was developed to train the expiratory muscles, right?
I don't know that that was really the thought, honestly, when they first developed the device. I think they were thinking it'll improve the respiratory muscles, potentially cough function. But when we started to use it in different patient populations, one thing that was clear was that when people were blowing through the device, they weren't just activating their expiratory muscles. And this is work that has kind of happened over time too, where people have studied, different researchers have studied what happens when you blow into the device outside of just activating your expiratory muscles. And what's been found over time is that when you blow into the device, if you look at it, for example, on fluoroscopy, the tongue base retracts, the soft palate elevates, the hyoid elevates as well, kind of more than it does just during kind of regular breathing. And so some of these are biomechanically similar-ish to swallowing, though it's 100% not swallowing. But also then EMG studies have identified increased activation of the submental muscles, of the pharyngeal muscles, increased kind of expansion of the upper airway. So I think there are a lot of different reasons why EMST might work for swallowing in addition to just expiratory strength and cough function.
What is the current evidence base on this?
Yeah, I think it's a pretty strong evidence base. So like I said, it started with, studies that were more focused on looking at expiratory pressure improvement in healthy young individuals. Then it expanded into sedentary elderly individuals where they looked at not just breathing, but also cough function. And I think that's where this kind of evidence base for improved cough started to develop. And since then, if you look in the literature, you can find studies in people with multiple sclerosis, with ALS, with Huntington's disease after stroke and head and neck cancer, and certainly in Parkinson's disease too. The findings are not always the same, which I think you would expect, right? The reason why individuals with Parkinson's or head and neck cancer have swallowing safety deficits or cough deficits are going to be completely different, right? The pathogenesis is going to be completely different. And so how and why it works and when it works is likely going to be different too. But I think if you kind of take the body of work overall, I think there's strong evidence to suggest that EMST can improve airway protection kind of in a large continuum of individuals, depending on what their specific deficits are.
Okay. It sounds like a really wonderful thing because it works on both ends of the continuum, as you said, both for cough and for swallowing. Are there any disadvantages that you would say that come along with the EMST?
Yeah. So, I mean, I think certainly not everyone can do it, right? You are developing very high pressures, intrathoracic pressures when you're doing the exercise. And so there are some individuals in whom it might be contraindicated. So individuals with uncontrolled hypertension, some individuals, post-stroke. I always get the question, like, who should we not do this in? And I'm always careful to answer because I think it's so individual, right? When we do these studies, we're really conservative, the reality. We have really strict exclusion criteria. And so we keep a lot of people out because we need to prioritize safety. But I think in the clinical realm, it's really important that you be collaborating with your team, the physicians on your team, the nurses, the physical therapists, the occupational therapists to determine, the candidacy of individuals for EMST. But again, generally, there have been studies even in individuals after stroke, right, doing this type of exercise. So I think generally its safety has been identified. So I think that's one thing. There's the kind of the contraindications. It can, in some people, it can be hard for them to coordinate the task. So it's not as easy as just breathing naturally. It's a voluntary task. And so individuals with severe cognitive dysfunction or severe issues, again, coordinating motor movements can have some challenges, but we've used it successfully in even people with progressive supranuclear palsy who have cognitive and motor coordination issues or ataxia. But it's going to depend on the patient, and you might have to start by kind of training the task first, right? Training them to breathe through a device with maybe no load and then starting to slowly increase the load. Yeah, I mean, it's like anything. I think it needs to be the right patient. And I think as clinicians, we are well prepared to make those decisions based on our evaluation of those individuals.
Yeah, great. We know from LSVT, at least from pilot studies or smaller studies, that it also improves swallowing, but it's not really a task-specific exercise. So it's really to improve voice and speech. And like you said, with EMST, we're really training cough or expiratory muscles. When would you then say, is it indicated to apply EMST primarily when someone has a weak cough or also when someone has dysphagic symptoms?
I mean, I think that's a great question. It's like the $1 million question. Who exactly is the right candidate for this and what can we expect to find? And I don't know that we have the exact answer for that yet. Like I mentioned before, there are different kind of physiologic reasons based on kind of what happens when you're exercising that might explain some of the findings, right? Beyond just improved cough function or reduced expiratory effort, if someone has reduced perihyoid strength for some reason, perhaps EMST is appropriate because, again, it's loading the submental muscles. Maybe it also, and no one has looked at this quite yet, we know that it creates increased activation of pharyngeal muscles, but we don't know exactly what happens after training. Do we see improved pharyngeal constriction? And so maybe individuals with reduced pharyngeal constriction, this would be appropriate for them. But I think when you're thinking kind of also big picture, I don't think we only have to think about it as an option for individuals that have kind of acute muscle weakness. But I think a lot of our patients, part of the issue that they have is that over time, their physiologic reserve lessens as well. And so when you start to think about the effort it requires to do some of these tasks, if their physiologic reserve is very small, that can be an issue when they get a pneumonia or when they fall and hurt their hip or they get a cold, right? It kind of pushes them over the edge. And so potentially you can also use it to improve their physiologic reserve so that they have a little bit more of a buffer in case something else comes along, a broken hip, a cold, or whatever it might be, a UTI in older adults, right? So I think that there are a lot of different reasons why you might use it. I think it's just important that as clinicians, instead of just thinking, sometimes I get questions like, well, don't you just use it for everyone? Like, it's great. Like, just go for it. And the reality is I haven't always used it for everyone. But I think that when I do use it, you need to be clear about why. And maybe you're doing something different for swallowing at the time, but then you're also pairing EMST because you think improving their physiologic reserve is important, right? So I think just always building that rationale is important as we develop our kind of treatment plans.
So through EMST, we are very focused on strengthening the muscles, the relevant muscles for both coughing or swallowing. What could we do if muscle weakness is not the primary pathophysiology? What treatment approaches do we have for this at the moment?
Another great question. So I agree that strength training is not the only approach we should be taking to improving swallowing or cough. They're both sensorimotor skills, basically. And so we probably also need to be using skill-based approaches to improve swallowing and cough. And certainly there is a lot of skill involved in many of the swallowing specific exercises that exist already or that kind of historically we've used. And then there have been some that really focused on the skill building, like biscuit, for example, but there hasn't really been that for cough. And so that's something that we've been interested in working on over time. We knew that the strength training approach worked, but we wondered, particularly because my work has been in movement disorders for so long, where the primary deficit is usually not reduced muscle strength. It usually comes along with it, but usually the primary pathophysiology or pathogenesis reason for the dysfunction is deficits in coordination, right? So we wondered if we could improve this skill. So that really has been a major focus of our more recent work.
Yeah, so you've published a paper last year in November, a randomized control trial, where you introduced a new method, which is more based on skill training rather than strength training. And you call this smTAP. Could you maybe explain what exactly it is and how this differentiates EMST?
Sure. So smTAP, or sensorimotor training for airway protection, is a treatment we developed 5-ish years ago. I developed it together with Dr. Karen Wheeler-Hegland, who's at the University of Florida. And that work started before I left there. And in some work that she had done, she identified that even when you present individuals with a stimulus that is above their threshold to make them cough, like they're going to cough if you present them with that stimulus, they can still modify their reflex cough. They can't not cough, they have to cough, but they might be able to change it. In some cases, they might swallow instead of coughing, or they might cough soft or kind of downregulate their cough. And so we knew that people could modulate their reflex cough. And so that was kind of the start of, maybe this is something we could kind of build into a rehabilitation approach. Simultaneously, we had identified in people with Parkinson's disease that it took more of a cough stimulus to make them cough. They perceived those stimuli as much more blunted than you or I would. They had disorganized kind of organization of their voluntary cough. But then we wondered, could they upregulate their reflex cough if we gave them a chance, even though they had these various deficits in kind of voluntary and reflex cough? And so now Dr. Alex Brandamore, as part of some of her dissertation work, she looked at this, and we looked at whether people with Parkinson's could upregulate their cough if we gave them biofeedback, for example. And we found that in the presence of all those other deficits we had already identified, they could still do it. And so we thought, let's give it a go. Let's try to make this kind of the foundation of the treatment approach. And let's make the target of the treatment, the ultimate goal to really be improving their ability to kind of sense. What we would want is for them to improve their ability to sense aspirate material and then cough effectively to that material. And so when we were developing the treatment, we really had that in mind as our ultimate goal. And so what we had individuals do is that we would present them with capsaicin, which is the cough-inducing stimuli we use in our lab, but at a low level. So not a level that would automatically make them cough, but at a level that they would just kind of perceive a tickle in their throat, basically. And then during the treatment, we would have them pay attention to that stimulus. So we wanted to bring attention to that stimulus while asking them to cough hard and giving them visual biofeedback of their cough airflow at 25% above their cough strength. So we were really trying to get them to cough harder than they normally would, but in the presence of a stimulus that we felt was salient. And so we had them do that with us once per week. They did 5 sets of 5 repetitions, so 25 coughs per day. If you know anything about EMST, that's kind of how EMST is developed, 5 sets of 5 breaths. So clearly we were trying to develop it in a way where the dosage was similar to EMST. We also knew that we wanted to have home practice. Any clinician knows you can't just treat someone once per week and then have them do nothing else the rest of the week and think it's going to work. But we also couldn't send them home with like capsaicin and a nebulizer and a pneumotac and all the other things. So instead, for the home practice, what we decided to have them do was use analog peak flow meters, so handheld peak flow meters. And we would set the little indicator at 25% above their baseline cough peak flow. And then they would practice the hard coughs during the week. And so they would do that 4 days out of the week, 5 sets of 5 repetitions. So the dosage of what is kind of usual for EMST was then also usual for smTAP. And clearly the reason why we did that is in the end, we wanted to compare the two of them. And we did do that. We completed a randomized clinical trial. It was funded by the Michael J. Fox Foundation. People with Parkinson's disease were randomized to receive either smTAP or EMST for 5 weeks. They met with the clinician once per week and then did exercise 4 days a week. And then we had them come back to see if it worked. And do you want me to talk about what we found?
Yes, please. Absolutely. Go on.
All right. Drum roll, please. I think we were happy to find really that both treatments worked. So that was like positive. You don't always have that finding when you do one of these clinical trials. We found that individuals who received expiratory muscle strength training had improvement in their MEP, which we expected.
MEP is short for maximum expiratory pressure. In the study by Michelle and colleagues, the MEP was measured by using a pressure manometer coupled to a mouthpiece. A clip was placed on the participant's nose to prevent nasal air escape. Then the participants were instructed to inhale as deeply as possible, seal their lips and teeth around the mouthpiece, and to blow into the manometer with maximal effort.
And had improvement in their voluntary cough peak flow.
Peak expiratory flow rate, or peak flow, is the flow rate of air forcefully expelled from the lungs in one quick exhalation. The normal peak flow value can range from person to person and is dependent upon factors such as sex, age, and height. In men and taller people, the peak flow is typically higher than in women or shorter people. In the study by Michelle and her colleagues, the peak flow was derived from cough waveforms obtained via voluntary cough spirometry.
And they also had improvement in their swallowing safety. In the smTAP group, we basically found all of that plus a little bit more. So in the smTAP group, we found that their MEPs improved, though MEP improved more for EMST, which I think makes perfect sense. We also found that voluntary cough improved, but in this case, more than was seen in the EMST group. And then something that wasn't seen in the EMST group, but we did see in the smTAP group, was an improvement in people's perception of the intensity of the cough-inducing stimuli, specifically at subthreshold levels. We call that the urge to cough, and their reflex cough strength improved. And we didn't see that in the EMST group. And we also found an improvement in swallowing safety in the smTAP group. So in this case, at least in this group of individuals, it seems like both treatments worked, but smTAP may have worked a bit better. And we thought that that was really promising. And I think something else that we were really excited to see is when you take the EMST findings, if you go back and look at past clinical trials, we essentially replicated everything that had been found. An improvement in MEP, an improvement in swallowing safety, an improvement in voluntary cough, and no improvement in reflex cough. And so I think that that's really positive when we're thinking about whether we kind of trust our findings. But again, I think it means that we have 2 strong treatments to have in our toolbox, depending on, the patients that we're working with.
Yeah, that's really exciting. And yeah, what you just said, I think that's promising that you keep on finding the same results every time you do it with EMST, which is, yeah, really promising and an indicator that it's really working and it wasn't just coincidence or anything. How would you explain the difference between the smTAP and EMST based on the pathophysiology of Parkinson's disease?
Like I said at the beginning, we developed smTAP to improve coordination and to focus on reflex cough. And so, whenever you go to find out the results of these studies, it's always like you've dedicated all these years of your life to doing a study and you don't know what's going to happen. And you wonder how you'll explain it when, the statistician comes back with the results. And in this case, it just felt really easy to explain it, right? It seemed very much based on the treatment itself and what the treatment was designed to address, right? And I think that when it came to smTAP, it was designed to address kind of this continuum of cough from voluntary to reflex with a focus on the urge to cough. And the urge to cough improved and reflex cough improved. And we didn't see that in EMST, which I thought made sense. And so I think that is really promising. And kind of one of our next steps is actually to pair the treatments together, because potentially bringing EMST together with smTAP or cough skill training of any sort might have an even more robust improvement in these outcomes.
Yeah, I was just saying if there's still a place then for EMST. Yeah, that makes totally sense to combine it and possibly have the best results even. One follow-up question regarding your study design. Did you have a long-term follow-up where you saw the participants again?
We didn't in this study. So this study actually had something I didn't mention. So half of the participants received a delayed baseline. So they had a baseline assessment and then they had 5 weeks of no treatment. And we reassessed them. And this was something that the initial grant reviewers were really interested in having, because they had a concern that, like, maybe if you just keep having people do MAP or keep having them do your baseline cough measures, maybe they just get better at it, right? And I think what was interesting in this group is that even though their MEP didn't change over that period, their cough actually worsened during those 5 weeks. So I think it really just further emphasizes the need to rehabilitate and to treat these sorts of cough deficits. Unfortunately, in this study, we didn't follow them after that, although there's been some work that we did in kind of the original EMST clinical trial where we found that if you take it away, certainly people's strength decreases, though it might stay above their baseline. It's going to worsen. It happens to all of us. I mean, if any of us stop going to the gym, we know what happens. And that certainly is just going to be accelerated in individuals, especially with neurodegenerative disease. And so we have a study right now, that same study that I mentioned, where we're pairing EMST and cough skill training. In that study, we'll be following people for 1 year after the treatment while they're doing a maintenance therapy, which we think is going to be important. We know that taking it away altogether doesn't make sense, but can we kind of reduce the frequency of the exercise and maintain outcomes, or maybe even continue to improve outcomes during that period? So that's something we're really interested in exploring. And in that study, we're also going to be looking at whether doing these treatments via telehealth is just as good as doing these treatments in person. We think we'll learn a lot. You can have me back in 6 years or something on your podcast to talk about that.
Great. That sounds really great. Yeah, and especially the long-term follow-up, I think, in the neurodegenerative disease is so important. And as you say, the maintenance exercises at home is really important as well. Yeah, really looking forward to learn more and to your results. Maybe one other question. Now, you've mainly conducted this work, or maybe with smTAP only in Parkinson's disease, right?
In long term, yes, but we have done a couple of feasibility studies. So we did a feasibility study in people with progressive supranuclear palsy, where we did just 1 session of smTAP. We were mainly interested in seeing if they could even do it. I think anyone who's worked with people that have PSP, it's a very difficult disease. It comes with a lot of cognitive involvement, a lot of kind of sensorimotor involvement. And what we found in just that 1 visit is that from the beginning of the treatment to the end of the treatment, their peak flow improved and they were able to do the exercise. And so certainly the next step is to do it more in the long term. We also have looked at cough skill training in individuals with ataxia with similar results, though really looking just at the feasibility at this point in one visit. So we think it's something that is easy enough for individuals who have cognitive dysfunction and individuals that are more motorically sensorimotor dysfunction as well.
Great. And not sure, did you look at swallowing with smTAP, if that improves or changes at all?
Yeah, so it's not in this first paper, but we did look at those results. We presented them at DRS this year, and they will be in a forthcoming publication. But we did find that swallowing safety improved in both groups, in the smTAP group and in the EMST group. And it wasn't more in one group or another. So it wasn't as if smTAP improved more or the EMST group improves more. And in that analysis, we also identified, so our primary outcome of interest, because we were interested in airway invasion, was the PAS. But then we kind of derived their digest safety ratings. And based on kind of their severity, we then looked back at the cough outcomes. Because one thing that people often ask us is, well, but does this work in like the most severe patients, or does it only work in the less severe patients? So we wanted to answer that question. And so even in our patients with the most severe baseline swallowing deficits, they still had a significant improvement in their cough function. And we think that's important because those are exactly the patients that we want this outcome in, right? If they are still having swallowing safety deficits, we want them to have a mechanism by which to clear the airway. So we were really pleased to see that finding.
I've got one more question about the swallowing parts with smTAP. You said that the participants improved their sensory capacities with the cough. Could this also mean that, for example, swallowing initiation could also improve?
Maybe, yeah. It's a good question. Yeah. I mean, there are a lot of possibilities, but we certainly haven't answered those yet. And I think that those are data that we're still kind of sifting through. We're really interested in looking at a lot of things, outside of PAS. And in particular, were people just generally coughing more than they were at baseline, which might actually be a good thing, not a bad thing, right? If they were more quote unquote silently aspirating before and then, changing to be more reactive to that. And then something that really is kind of the next frontier is then how effective, we're doing measures of cough in a lab using capsaicin. What would be really great is to also know how effective that cough is in the presence of aspiration, right? So, we're working on different ways of measuring and looking at that as well. But yeah, really great question. And I don't have the answer yet, but hopefully you or others would like to help us answer those questions. We can do the work together.
Yeah, it's always so interesting. There's so much you want to look at, but you can't really put it in all in one trial. Otherwise, you would assess one participant for so long
Exactly.
and do so many outcome assessments. So
Yes.
We have discussed two different approaches for the rehabilitation of airway protective disorders in people with Parkinson's disease. Could you briefly summarize what the main similarities and differences are?
Certainly, EMST is primarily a strength-based approach to rehabilitating airway protection, whereas smTAP is more of a skill-based approach to improving airway protection. Another similarity is they both use handheld devices, which I think is not a small issue because something that we've identified in this work is our treatment adherence is very good for both EMST and smTAP and cough skill training. And I think a lot of that is because people feel very empowered when they have something in their hands. They feel like they can tell whether they're doing it correctly or not, even in the absence of a clinician. And so both of these, I think, have that in common, that they use a device. And because of that, I think we've shown very good adherence for both treatment approaches. Both improved kind of both ends of the continuum. So both can improve the swallowing end of the airway protection continuum and the cough end of the airway protection continuum. Both improved expiratory pressure, though EMST improved it more. Both improved voluntary cough strength, though smTAP improved it more. And I think just the main difference was really that smTAP also had that improvement in reflex cough outcomes, both the perception of the stimuli and then the strength of the reflex cough. But I think They both have a role to play. I'm definitely not saying throw away your EMST devices. On the contrary, I say hold on to them. I think that they're an important part of the puzzle. And now we just have one more tool, I think, in our toolbox that we can use to really improve the lives of our patients, not just in the short term, but hopefully in the long term. So we're really excited about continuing to explore how we can refine both of these treatments, because I don't think that we should just say, oh, it worked in this one study, so let's just like keep doing it this way forever. I think there are a lot of ways that we can refine it to make them more effective, but also to make them even more accessible for clinicians as well. And so we're working on a lot of that right now, and we're excited to be able to share that information soon.
Yeah, wonderful. And make it more accessible to patients as well. As you just said that you're looking at telerehabilitation, that's definitely something, we're looking forward to as well.
Yes, thank you.
Thank you so much, Michelle. We really appreciate it. Thanks for taking the time and sharing your expertise. We hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website, dysphagiamatters.org. Thanks so much for listening. Thank you, Michelle, for coming on the show. Take care, everyone.
Thank you.